Hi guys, Dr. Douglas Gillard here once again. We got some work to do. I missed last Thursday's lecture. I was at the National Board of Chiropractic Examiners writing questions for you guys. But nevertheless, we still need to make this up because now we're way behind. Here is a YouTube video for you. It is going to be on your test. I'll post the slides on Brightspace. And it's actually quite an important topic. The topic is GERD. Everybody knows what GERD is, Gastroesophageal Reflux disease. Huge problem, not only in America, but across the world. Can turn into a Barrett's esophagus, which can turn into the dreaded and feared esophageal cancer, which is terrible prognosis. So let's get to it. Occurs, let me turn my little highlighter on so I can, there we go. So it occurs when a patient frequently regurgitates or burps up stomach contents into the distal esophagus or even further. And what does that mean? Regurgitate means we've all regurgitated a little bit of stomach contents and we taste that sour taste in our mouth. It's different than throwing up, right? Throwing up is where you projectile vomit. This is just burping up. But that acid is quite damaging to the tissue of the esophagus. It's not designed for that. So it can irritate, inflame, and even erode, or even worse, transform the tissue of the esophagus. The common person calls the pain associated with GERD heartburn. They ate a spicy meal a couple hours after they eat, about an hour and a half exactly, according to research, they start getting a pain in their chest, almost like a heart attack, and that's known as heartburn. But heartburn is caused from gastroesophageal reflux disease. Basically, you're burping up food. Now, the pain that occurs is because the stomach contents, namely the hydrochloric acid and especially pepsin. Pepsin's probably worse than hydrochloric acid. It's a very good protein eater. It can eat right through your esophagus. That stimulates nerve endings down in the lamina propria, and that's what causes the pain of GERD. Here's just a blow-up of the distal esophagus. This is actually the abdominal esophagus. I'm not going to go crazy histology on you here, but this is the lumen, right? This is where your food comes through. You got those basic three layers. You got an endothelial layer, which is in pink. You can't see the cells, but they're stratified squamous, and then they morph into a simple columnar without goblet cells, without those type of mucus cells. Then you have a lamina propria right here between the pink and the orange. And you can see the authors there's a little nerve fiber right there. There's an artery in the vein. There's lymph in here. So all you have to do is burn that acid. Doesn't have to go very far. It just has to burn through this pink layer, and you're into a territory, lamina propria, where there is pain fiber, and it will hurt. And that's where the pain of this comes from. And it's not hard to go through the next layer and get into the submucosal layer, where you got some major blood vessels and veins, lymph system, as well as nerves, and then it can really hurt, and it can bleed much more because these vessels in the submucosal layer are much bigger. Just got to pass through this layer. Might as well do that. What's that? Guys got boards coming up. What's that third layer of the mucosal layer called? Epithelial, lamina propria, and muscularis mucosae. Doesn't do much in humans. Might help a little bit with peristalsis, and that's about it. Okay, so medically speaking, the inflammation associated with GERD, it has a name, and that if this layer, let's say you start burning and damaging the lamina propria here, and maybe even the next layer down, submucosal layer, that damage needs to be cleaned up, right? All those cells that are killed, who's going to do that? It just doesn't sit there. An inflammatory process starts, and now you got an inflammation, and it's hurting, it's stimulating those nerves. And it causes an inflammation, and there's the itis, that means inflammation, an inflammation of the esophagus. So you have Some people with GERD don't go this far. They don't have an inflammation and big trouble. They just have a little heartburn after they eat. Some people have pain all the time, and it gets to be a really big problem. That's because they have reflux esophagitis. They have an inflammation of the esophagus. Epidemiology, this is the most common diagnosis made by gastroenterologists in the United States. Remember, for boards and things like that, you should always know who to refer. If your patient has stomach pain and they're not sleeping and they can't eat and they're losing weight, who do you refer that patient to? Right here, gastroenterologist. What if they can't talk? What if their vocal cords have problems? Who do you refer them to then? Eyes, ears, nose, and throat doctor. That's the division line. Anything below the larynx is gastroenterologists. But when it involves the voice box itself, then you get an ENT doc who specializes, and they specialize like crazy, right? You look for one who specializes with the larynx. So 20 million Americans have this diagnosis. Typically strikes people over the age of 40 when the lower esophageal sphincter starts to degenerate. Everything dries up and gets weak when you get over 40. It's not the curse of getting old, I guess. And so increased prevalence with increased age. It likes old white men particularly, but it's not uncommon for children. My grandson went through this for about 6-8 months. It's kind of came out of it now, but so it can definitely affect children. Symptoms strike about 40% of adults at least once a month. That's a crazy number. That's like 11 million. Well, maybe not quite that many, because not all of this 40% are going to get PPIs, but that's a huge number, right? 40% of Americans have one bad night because they have GERD. In 2013, 11 million people were prescribed PPIs. So that's proton pump inhibitors. That's the number one treatment for this. So some are over the counter nowadays. We'll talk about those. That is the number one medication for GERD. Just said that. And what is the pathophysiology? What causes GERD? GERD is caused by hypotonicity of the lower esophageal sphincter. What does that mean? We talked a lot about the esophagus. I'm not going to dig back in that too much, but that's that muscular layer that that's always closed and it's tight, and it normally prevents stomach acid from coming back up the esophagus. As you get older, or if you get diseased, you have a problem with that. It starts to loosen up, and then regurgitation of stomach acids and things like that can go right back up into the esophagus and start ripping up your esophagus. Okay, so without proper tones, stomach contents more easily regurgitate into the distal esophagus, and they damage the tissue. This is pepsin and hydrochloric acid. That it's designed to rip up protein, and your esophagus is protein. Okay, especially proximal to that Z line. Remember, the Z line is the line where the epithelium of the esophagus meets the epithelium of the stomach. And the distal part of the esophagus is covered with simple columnar. That can handle a little acid. But if you go above the Z line, it can't handle acid. That's stratified squamous. It's not designed, and you will rip that up. Specifically, it's non-keratinized stratified squamous. We talked about that. Just like the covering on your skin, only it's missing a couple layers. All right, here's the stomach. Here's the diaphragm right here. There's the diaphragm, or the esophageal hiatus is the hole through the diaphragm. The esophagus passes, thoracic esophagus. This is the abdominal esophagus. If you could look through the coloring zone, you see a little Z line. And that's the meeting of this simple columnar tissue, and this is stratified squamous. And where they meet, the tissues are different colors, and we'll see some pictures of that in a minute. Lower esophageal sphincter is right in this region, right in here. It doesn't it's usually right where it penetrates the diaphragm. This area is beefed up. And it is kids hour out there, so sorry about that. This is a late. I usually do these videos in the morning, but risky times. What increases the chances for GERD? Overeating, especially if you know you have heartburn and trouble with GERD. Don't overeat and stretch your stomach way out. Then you trap air in there, and a little bitty burp will blow the stomach contents right back up the esophagus. Really easy. Eating too late at night, especially a combination of these two. It takes time for you to digest your food, especially the older you get. And some people will we talk about the stomach, some people have a problem with processing that food, and it can take hours. Normally it's like an hour and a half or so. Some people can be 3, 4, 5, 6 hours to get to empty their stomach. If you lay down with that much food in your stomach, you don't have gravity holding that food in your stomach, and then it's much more easy for it to come up. Especially now, everybody repeat after me. Right is wrong. Right is wrong. If you do have a trouble with GERD and you have eaten a couple hours, or pretty soon, like an hour before bedtime, and you're kind of full, do not lay on your right side. If you lay on your right side, the fundus is taken out of the play, so to speak, football analogy. The fundus won't catch the food, and the fundus is to the left. Therefore, this fundus will be sticking up in the air, and it won't catch the food. Your food in your stomach or the digested food, the juice, will have a straight shot right into the esophagus if you sleep on your right side. So always sleep on your left side especially if you overeat and you have trouble with GERD. And then you eat the wrong foods. You got to be careful with what foods you eat. And we'll expand this list in a little while. But alcohol, notorious for causing GERD. How can alcohol cause GERD? What is alcohol? Is it a stimulant? Well, maybe if you drink 10 shots of moonshine, it's a stimulant. But in moderate doses, it's a strong depressant, and it relaxes the muscles, and your lower esophageal sphincter is a muscle, so that gets relaxed. And if that gets relaxed and you lay down, it's easy for the stomach contents to come right back up. Valium, common drug that people are on for depression, anxiety, and things like that. It's a good muscle relaxer too. That's a strong depressant, probably stronger than alcohol. So when you get a sprained ankle or something and you have anxiety over the ankle instead of Soma, which is a popular muscle relaxer, that should be on the list as well. They give you Valium. That's not a good thing. You better be careful. Better sleep in your recliner, or better go to bed with an empty stomach, or you're gonna rip up your esophagus, and you're gonna be in pain for a couple of days, if not longer. Chocolate also loosens the lower esophageal sphincter. Oh, there's Soma right there. Muscle relaxers. Valium is a muscle relaxer as well. It helps depression a little bit too, and anxiety. Hiatal hernia, we'll talk about. You will know the different types of hiatal hernias. I won't go into that right now, but stress turns on sympathetics, turns on acid production. Osteoporosis is an interesting one. People with osteoporosis often have gastrointestinal problems as well. We don't know the mechanism behind that, but it's quite true. And then some people, the lower esophageal sphincter gets loose, and we don't know why it is, and they have GERD. Some other causes, some of these we'll get to more. Some of them we talked about. Remember some of the esophageal contractility problems, where peristalsis is screwed up and weak, and therefore if you burp up food into your esophagus, you don't make peristaltic waves to push that fluid out, and it just sits there. Zollinger-Ellison syndrome, big problem. We're going to talk a lot about that. This is a gastrin-secreting tumor, and we know gastrin has receptors on the parietal cells in the stomach. What do parietal cells do? Board time, right? Your boards are coming. What do parietal cells secrete? Good. Hydrochloric acid. They have proton pumps. What else? Pepsin, or pepsinogen, which is converted to pepsin. One more thing. Good. Got it. Intrinsic factor. Hipster. Remember the hipster? I'll show you the hipster if somebody did a little of this lecture, I think, and maybe they showed you the hipster. Anyway, we'll get to that. Motility disorders we talked about. TLESR, transient lower esophageal sphincter relaxation. Not sure if we got to that. I might have taken those slides out, but it's a kind of an idiopathic thing where the sphincter doesn't work. Weak esophageal peristalsis, we said that. Obese. Now, how about obesity in pregnancy? How can that increase the chance of GERD? Pregnancy makes you hungry and you want to eat more? No, that's not it. Well, both of these two, obesity, especially the Homer Simpson belly, that increases your intra-abdominal pressure inside your abdomen. And that pushes, that squeezes the stomach. And it's like squeezing toothpaste, and the tube, the opening of the toothpaste goes up into the esophagus, into your chest. So plus the chest is negatively pressured too, right? You have a negative interthoracic pressure. And so it's always kind of sucking the stomach contents upward. What causes the pain? We already said that. I guess we're going to go a little deeper here. The pepsin and the acid and the pepsin weaken and destroy tight junctions. So now we're talking about the epithelial cells of the esophagus. We know that they're held together by what? If you said tight junctions, wrong. Tight junctions do what? Tight junctions block things from going deeper or penetrating between the epithelial cells. They're not very good at holding the two cells together, right? Those are who holds those together? Hemidesmosomes? No. Hemi hides in the basement. Hemidesmosomes connect basolateral or the bottom surface of the epithelial cell to the basement membrane beneath. It's desmosomes are the ones that do that mainly. Okay, so with acid, you get the tight junctions get destroyed, and aka for tight junctions, zonal occludens or macular occludens, they get destroyed. And now it's really easy once you burp up acid. There's nothing really keeping it from going down to the deeper tissue where the nerves are. So it scoots right down into the lamina propria, and maybe it gets into the submucosal layer, and it hurts. So here we go. So here's the lumen up here. This is where your food and the bolus of food is sliding. And if you're burping up stuff, well, this isn't really. This is these are intestinal cells, right? Microvilli. But we'll pretend if you chop these off, you got yourself better cartoon of esophageal cells, but the same cell adhesion molecules are there. So there's the tight junctions. That's why the acid normally it can't get through here, but with time it wrecks these. And once it wrecks these anchoring junctions, the desmosomes and zona adherens, they're terrible at stopping stuff through from getting through. Viruses, anything that gets through here. Same with the gap junctions have no stopping power at all. It just rips right through all these. And now down here, here's your basement membrane. Right underneath this, there's a big blood vessel, and you could submucosas down in here. So nerves. I didn't draw the nerve. Oh, I guess I did. I drew a little nerve in here. There's a nociceptive nerve in the lamina propria. So the acid, once it gets through these things, it just drains between the cells of your esophagus and stimulates, burns this nociceptor. That sends a signal to your brain and goes, hey, I got pain coming from somewhere. It's not. Is it a really good pain? I mean, do you know exactly where it's coming? No, this signal is not very good. The brain isn't very good at picking out where this is coming from. It may come down by the xiphoid. It could come from the sternum. Could come from the heart. Could come from the throat. But usually it's said like it's a sternal type or a retrosternal pain is associated with GERD. What causes the pain? I already said this. Once these junctions are weakened or destroyed, acid can move deep. And everything I just said, exactly. You could read that again if you want. Here's a little cartoon of all this happening. They don't show tight junctions very good. But normally the tight junctions keep the little yellow molecules or acid. The triangle molecules are pepsin. They're kept out of there pretty good. But when the tight junctions get broken, here they have broken and the cells now pull apart. It's broken through the other cams as well. And now the pepsid just goes right down through the stratified squamous layer, and it gets down to where the nerves are, and it hurts, and you can see it's getting worse and worse and worse. So pretty cool drawing. Okay, so therefore, the point of this slide is, why is it, let me ask you this first. Did you know people who have really bad problems with GERD, they finally go in to get an endoscope stuck down their throat to see the GERD, and the doc finds nothing? Is that rare? That is not rare at all. About 50% of people who suffer from chronic heartburn and GERD symptoms, they stick that scope down there, they don't see anything. Why is that? Tight junctions are ruined, so the pepsin and the hydrochloric acid, they just zip right through here. They actually don't damage these cells too badly at first, and they just zip right through here, and they get down into the lamina propria and damage that, and that's where the nerves and blood vessels are. So these top superficial cells can look pretty good, but when the problem, that's why if you have a big problem with GERD and your doc, your gastroenterologist, does an endoscopy and says, oh, everything was fine, and he doesn't take any tissue samples, that's not a good thing. They should take some tissue samples to make sure that these cells haven't morphed into precancerous cells, because 50% of people yet they have GERD, but they don't have symptoms or visible symptoms. You still got to take tissue samples. I had big trouble with GERD for probably 5 years. Finally, after I got this class and really started studying this stuff, I finally got rid of my GERD. It's been about a year now. And I went to Stanford. No one could fix me. It's on PPIs and everything. All I did is figure out what was the matter, loose lower esophageal sphincter, and now I can eat. I can eat a lot. Now I don't have any trouble with anything. Anyway, I digress. I'm trying not to digress. Sorry. So if you have GERD symptoms, if you have heartburn pain, and the doc sticks a scope down you and there's nothing there, you have a new diagnosis. You don't have GERD anymore or erosive esophagitis. You have NERD. So once the scope goes down, you're going to either be classified as a NERD or a GERD type person. So this is, I guess, Wiki says that's a nerd. So I guess that looks like a nerd. All right, 50% of heartburn people therefore have the diagnosis of non-erosive reflux esophageal or non-erosive reflux disease, or NERD. Now the NERDs, eventually, if it keeps going on and you don't treat it, it could definitely turn into GERD, where you get ulcers even. It could turn into real erosive esophagitis, where you have lesions down there. But a lot of people, a lot of nerds running around there still with quite a morbidity. Doesn't mean the morbidity is any less. Other diagnostic tools. So if you're a nerd and they don't see anything and they forgot to take tissue samples, which I've had probably 3 or 4 scopings, none of them bothered to take. If they would have taken a tissue sample, they would have figured it out. Too much of a hurry to get more patients in, I think. But there's other things you can do. There is a 24-hour pH study called the esophageal pH test. That if the endoscope was negative, you go to this esophageal pH test. Pretty decent specificity, 95%. Sensitivity is not good. So rate of false positives is not the great. I mean, it's pretty low. So if this test is positive, it's positive. They put a little tube through your nose, and it's like mammometry. I think I showed you that. It's kind of like a mammometry tube, only it doesn't have pressure sensors. Well, probably it actually has those too, but it has a pH sensor at the end. And you put that right down by your lower esophageal sphincter. You wear it for 24 hours and you eat your normal thing, and normally a person wouldn't have acid coming up high into the distal esophagus, but people with that weak lower esophageal sphincter, this thing will register maybe halfway up your esophagus, and then you know you got a problem with your lower esophageal sphincter. There's some new versions which are surgically implanted into the distal esophagus, and they supposedly fall off. They're still in the experimental stage, so I think I probably would go with the old tube down the nose. The good thing about these, you don't need to tube down your nose. They clamp them down there, and it supposedly falls off. Nerds are a tough group of people, though, to treat. They don't respond well to the medication therapy. So typical therapies for GERD or NERD are H2 blockers, which don't work very good. PPIs are by far the king of the treatment. Prokinetics work, but they have a lot of dangerous side effects. The good ones have been banned in this country. So it's really PPIs, and you can take these at night. So only a small number of NERD patients will eventually... the good thing is, that's what this is saying, the fear of the NERD and the GERD patient is to get lesions and ulcers. Like canker sores. You get canker sores in your mouth. Those things hurt like crazy, right? But they get better. You can get giant canker sores down from that acid reflux, and you can't eat anything. You're going to lose weight like crazy. That's called erosive esophagitis. And for whatever reason, even though the PPIs don't work good, we'll see some statistics on that, I think, unless I took it out. They don't seem to go into the severe bleeding chronic erosive esophagitis. So only a very small number of them go. GERD patients go down this road much more quickly. You don't want to develop ulcers, bleeding ulcers. And it's not in the stomach and duodenum. We call them ulcers. PUD, peptic ulcer disease. They are ulcers of the esophagus, but you just call them, the diagnosis is different. You call it erosive esophagitis. If the endoscope does reveal tissue changes, then you've got obvious erosion and stuff they can see. Then you don't really say you have GERD anymore. You still have GERD. That's like a general category. It just means you're burping up acid. But now you got a more serious diagnosis of erosive esophagitis, or erosive reflux esophagitis is probably more correct. The symptoms of GERD is a burning type. I can tell you, I've had this, struggled with this for many years. It's literally a burning pain right in either the sternum or around the sternum, or it can fake a heart attack. It can be right in the left side of the chest, right over your pec muscle. It can be, in some people, it's down where your xiphoid is. Therefore, you can get it confused with what? Another thing we're going to study, chronic stomach upset. That's called dyspepsia. So dyspepsia and GERD can overlap. I had problems with my throat, actually, until I figured out I was burping it up all the way into my larynx. I actually ended up having vocal cord ulcers, and that's when I put things together. But it can affect the throat sometimes if it comes up at night all the way into the vocal cords. Again, these symptoms are called heartburn by lay people. You should not write heartburn in your notes. That's not good. Sour stomach, indigestion, upset stomach. These are all lay people terms. Other common symptoms, acid regurgitation. That's when you burp up. I still have trouble with that. I didn't fix my lower esophageal sphincter, but if I eat too much, I get that quite a bit. And we've all had that. You burp that bitter, sour tasting thing. It's like, ugh, and then swallow it. You can have dysphagia. How can you have dysphagia? Remember, or odynophagia, right? Painful swallowing. Odynophagia, painful swallowing. Make sure a test is coming. Make sure you know those. Dysphagia, trouble swallowing. Well, if you rip up your distal esophagus, that food bolus has to slide over it. And if it's all ripped up and raw, it hurts and it gets stuck maybe, and you have trouble swallowing. And so not from anything really wrong with esophagus mechanically, it's just because it's all ripped up from the chronic exposure to acid and pepsin. Hypersalivation, I've been down that road as well. It's like you're spitting up, or the mucus is coming up all the time. It can be coming out in your fecal material, can be really mucousy as well. The body, if you have erosion of remember we talked about the esophageal, the mucus glands. There's cardiac glands. There's 2 types of mucus glands. So the esophagus can produce a lot of mucus. And if that tissue is irritated, it'll produce mucus like crazy. Less common, but I'm a member of this family, dysphonia. So I had trouble speaking and lecturing. I was having trouble because my vocal cords were ripped up by the acid. Chest pain, GERD's the most common cause of non-cardiac chest pain. Hands down. It's almost impossible to tell from a heart attack. If you have when you first a really bad attack of GERD, where you really probably get ripped into your submucosal layer, you have to go to the emergency because you think you're having a heart attack. And when you get to the emergency room, they can't tell. Got to get an EKG strip going, test your blood for what? We didn't cover that yet. But you other people who are watching, you should know that. What do they test your blood for to rule out a heart attack? You don't have to name me all 3 of them. Troponin levels show up. Okay, but it's typically a pain retrosternal. It feels like it's right between your sternum. The symptoms typically show up 1.5. There's been some big research on this. On average, you go eat whatever type of food, Mexican food, really hot, spicy food. It's notorious for doing it. Feels great until about 1.5 hours, and then you start burning right underneath your sternum, or for you lay people watching this, your breastbone. But we don't call it breastbone, right? It's your sternum. Why is that? Why is there always that delay? Well, when you eat food, even if it's hot, spicy food, the pH is still really high. It's probably 7 or 8 or something like that. And so any acid you have in your stomach is completely diluted. That's why Tums work so well. That dilutes acid. Food dilutes acid. So it takes a while for the parietal cells to start cranking out pepsin. Did I say pepsin? Did I say that before? Pepsin comes from the chief cell. Sorry about that. I think I did say that. Right? Chief cells secrete pepsin. Anyway, so it takes time before the acid and the pepsin to get up to speed. Let's see. So the worst meal of the day is usually dinner, because it's usually the biggest meal, and oftentimes people eat dinner and they go right to sleep, and that's big trouble. We talked about that already. There's a study of 500 patients was done by Jolson back a long time ago, but still would stand today. So they had patients mark down in a diary when they felt the GERD pain, and they had to eat exactly the same times. So at 6 a.m. they had breakfast, and by 7:30 the pain came, and then it kind of ramped down. Same thing, about 1.5 hours after the big meals when the pain came. All right, look at lots of stars here on this one, so make sure you can see the question. Which of the following is not a cause? Those are my classic questions. Which of the following is not a cause, our classic trigger of GERD? So alcohol, spicy food, chocolate, all the good stuff, right? Chocolate's notorious for ripping up stomachs. People have no clue about that. No clue of that one. Red sauces for Italian food. Large volumes of food. Overeating will trigger it. A really high protein fish type meal without any carbs to kind of dilute it out. That really makes the parietal cells crank out acid. Going to bed right after sleep, especially sleeping on, what was that? Right is wrong. Don't sleep on your right side. Always sleep on your left side. We'll look at that mechanism more when we talk about the stomach. How to make the diagnosis. Patient complaints is a pretty good way to do it without doing some fancy testing. If they have that pain underneath, it feels like it's coming underneath their sternum, and it occurs an hour or two after eating a spicy meal in particular, or eating a bunch of chocolate, that's a pretty darn good indication that they have a weak lower esophageal sphincter. It's letting acid and pepsin burp up or regurgitate up into the esophagus. So pretty easy. There's some tricks you can do too. So when that pain starts about an hour and a half, give them some acid, or give them some acid. Give it some Tums. Let them take some Tums. These things, God, I probably went through bottles of these till I figured the things out. They work great. They dilute the acid in the stomach, and that's great. What about protein? Some people say, how can you break down protein? Yeah, you got trypsin, right? When you get down into the duodenum, trypsin's a very good protein breaker downer too. It probably will, some of the protein won't get broken down, but you don't have to worry about that. But you do have to worry about something. What do you got to be careful, you people out there? What about you stone formers? Anybody had a kidney stone? Yeah, one of the most painful conditions under the sun, right? People are on Dilaudid, it's more powerful than Oxycontin just to knock the pain out. So if you're stone former, this is calcium carbonate. So you can get a lot of extra calcium, and your kidney's got to process that, and they can't process it. You get these darn kidney stones, and they're formed in the kidney, the renal pelvis. It goes down through the ureter, and it gets stuck, and oh my God, that hurts so bad. If it gets into the bladder, it can get stuck here and wreck your bladder, right? You can't pee anymore. You can't get the urine out down into the urethra. So these stones will hopefully get to that this quarter. And I guess you should know this. What is a stone? What's a kidney stone called? Urolithiasis. Make sure you know that word. I could throw that in the test. I should have put a star there. Urolithiasis. Urolithiasis. I say lithiasis. That's the way I've always said it, but that's the official pronunciation. Proton pumps, how to make the diagnosis. Another trick. So if you've had GERD for 6 months or a year and nothing's helping, and they prescribe proton pumps, which you can buy over the counter, right? Prilosec's over the counter now. See how it takes a while. It takes like a couple weeks for them to get working. But if that dramatically improves your symptoms, it shuts off acid, turns off the proton pumps, which make acid. You got GERD. And then if you want to test it further, I wouldn't recommend this, but if you want to test it further, stop these cold turkey. Just stop them and keep eating normal. If the pain comes back with a vengeance, you definitely got a loose lower esophageal sphincter. You got GERD. How you really confirm the diagnosis, we already said that. Endoscopic findings, that makes the diagnosis. And what do they look like? You get these rips, linear erosions in the distal esophagus, and that's all you need. Now that makes the diagnosis. You still have GERD, that's the cause of it, but now you got the GERD has caused another condition called erosive reflex esophagitis, or just reflex esophagitis, or erosive esophagitis. I've heard authors use all those three things. And yep. What about a biopsy? There's my rant. A biopsy should always be performed. If the doc doesn't see anything and it's been really disabling, they can't just rush and say, oh, you don't have anything to worry about it. They need to take some histological samples, and you need to tell them that you know what you're talking about. That's standard. Assuming you're really disabled, because you might be a nerd. You might have the acid leaking down through the epithelium, and it's ripping up the submucosa underneath, and it's not really showing in the top. So the only way you can find out, maybe you have a Barrett's esophagus starting. But although there's visual signs for that, so I don't want to get everybody too scared on that. But they should. All the authors that I recommended say people with significant symptoms, they should be biopsied. Okay, and you can catch cancers and things like that too. Because remember, 50% of the people who go in with GERD symptoms they have a negative endoscopic evaluation, and they are nerds. Okay, no stars on this slide, right? So my students can relax, but there is a more gastroenterologists, and the research can classify things. Erosive esophagitis can be classified by something called the Los Angeles Classification Scale, and it's based on the magnitude of ulceration that is in the esophagus. How bad are the tears? How bad is your esophagus torn up? There's a LA, A, B, C, and D. Again, my students don't have to worry about it, but there's the first grade. It just looks kind of red, maybe one little lesion. There's a little lesion there. And then go to the extreme, you got these gigantic ulcers. So these people are typically really, really symptomatic. Back in the day, they used to do what's called a barium swallow to try to identify GERD. Complete waste of time. I don't think, at least in our country, no one would dare do that anymore. They swallow barium and they see if they can look for ulcers in the side of the esophagus. Look at the sensitivity and specificity are 20%. Absolutely, anything under 50% is basically worthless. So this test is completely worthless for looking for erosions. Endoscopic eval is the gold standard. There are some differential diagnoses, and the big one you got to watch out for, especially if you have a heart condition and GERD at the same time, is angina or a myocardial infarction. Both of these can present just like GERD. You can't really tell them apart. Angina is the preludes to a heart attack. Myocardial infarction is a heart attack. And a myocardial infarction, you can die from that if you don't get to the hospital. You got 20 minutes. If you got a blocked coronary artery, you got about 20 minutes to get that unblocked. So you got to go right to your closest hospital. And if you're old and have a heart condition, you better find out what type of cardiac unit they have. They better have a cath lab, and they better be up to date, or you better find where you're going to go. Pericarditis we're going to talk about, that can also present with these same symptoms. And I said dyspepsia can have sternal pain as well. It's usually epigastric pain by the xiphoid, but these can all overlap. The treatment is acid suppression therapy. That's the cornerstone of treatment for GERD. And the star of the show is proton pump inhibitors. And do they work? They really do work in most people. H2 blockers, they don't work very good. Usually GI docs or your primary doc will start you out, and these are over the counter. You can get prescription ones too, but over the counter are fine. I actually like the prescription. I like Prokinetics, worked really good for me, and that's prescription. But you can get Prilosec as over the counter. The prokinetic therapy we'll look at, that's designed to tighten the opposite of a muscle relaxer, designed to tighten the lower esophageal sphincter. But again, lots of trouble with those. And then the other treatment, you got to modify your diet. You can't be eating spicy food with margaritas until everything is healed up. And then, you don't want this to keep coming back. So you got to make some lifestyle and dietary changes, at least until the lesions are healed up. Some other rules: don't go to bed for 3 or 4 hours after a meal. Eat a meal early. Eat at 5 o'clock, when the restaurant's open, or even earlier. If I eat a gigantic meal, I like to eat about 3 in the afternoon or even 2 in the afternoon. If I eat at 6 o'clock, I'll be sleeping in my recliner. I'll be sleeping upright because I won't digest it, and I don't want to start the GERD stuff up again. Don't overeat at dinner time. Avoid the foods, right? Alcohol, caffeine, spicy foods, chocolate, fatty foods. I don't know if this author put that in there. I don't know if that one. High protein should have put in there instead. There's the high protein there. Tomato-based foods also, lasagna, spaghetti. Red sauces can also do the trick as well. Stop smoking's been associated with GERD as well. I'm not sure what the mechanism is on that. Another trick is to put some blocks under the head of your bed. It's like sleeping in a recliner, to jack it up. That way you can have a little bit of gravity, keeping the stomach contents in there. That didn't really work that good for me. I have to go in a recliner if I eat a big meal late at night. Don't sleep on your right side. Right is wrong. Again, I don't know, that's like the third time. You know that's going to be on the test, right? Lose weight if you're really overweight and have a Homer Simpson stomach. You lose weight, that'll help decrease the intra-abdominal pressure. And then go for some over-the-counters. You got antacids. If you are going to go have Mexican food and you know you're a GERD patient, you better have some Tums around. You know, after you're all done eating, within an hour and a half or so, probably within an hour and a half, start taking Tums or milk of magnesia. All these Tums has got to be by far the king here. There's some acid chewing gum. That stuff didn't work at all for me, but maybe for some people it does. But it's on there. H2 blockers you can get over the counter. There's been research on these. They are just like they say, they block the H2 receptors. We'll look at that, which stimulate parietal cells. Well, maybe I'll actually look at it in a second. They're about 50%. It's hit or miss with these. You've got a 50-50 chance these things will help. They didn't help me at all. But H2 blockers, problem with the good thing about them, they don't cause osteoporosis. And there is kind of some smoke. We don't see the flames yet, but there's some smoke that the PPIs might be associated with osteoporosis. And that's a bad thing. The H2 blockers, I've asked this a few times. Why would I make you know these? Because your patients are going to come in taking these things, and you got to know what they are. So Tagamen's been around forever. It used to be prescription back in the day. Zantac used to be prescription back in the day. These are over the counter now. Pepsid AC. This Avidid, I've never even really heard of that. That was listed by the authors though. The H2 blockers, you have to take them twice a day. Higher doses seem to work a little more rapidly. PPIs take a couple weeks to get in your system, to get working. The only time you would take H2 blockers is if PPIs weren't working at night. If you're waking up in the morning with a sour stomach. PPIs tend to kind of poop out over the nighttime. They lose, because you take them first thing in the morning. You only take these PPIs once a day. And so by adding an H2 blocker at night, that sometimes gets you over that nocturnal acid, stops breakthrough acid at night. So how do they work? They work by blocking histamine, not the H3 histamine. That allergy season is a H3 type receptor, but this is H2 receptor. H2 receptors are on parietal cells, and it literally competitively or competes for the binding site, and it can block that. If those sites are blocked, your parietal cells don't produce as much hydrochloric acid. Oh, I guess we are going to look at it. Here's a parietal cell in a typical fundic gland, and we're going to study all these ACH receptors. There's a gastrin receptor, and then there's an H2 receptor. So histamine can come in here. Here's a histamine molecule and stimulate this to make acid. So if we block these receptors with whatever, one of those H2 blockers, if that gets in there, this can't bind, so you can't make acid. But you can immediately see the problem with this, right? It doesn't do anything for a gastrin receptor. Acetylcholine, get a little sympathetic stimulation and release this acid, or release ACH from enteric plexus. Nothing to block that. So that's the reason they don't work very good, because they only block 1 out of 3 receptors. There's plenty of other things that'll stimulate the hydrochloric acid release. Prokinetics, they work, but as I said before, they're dangerous. They're banned and not improved. The good ones have been in Europe and the United States are banned because of ventricular fibrillations and all sorts of cardiac arrhythmias. So you don't want to get that going. So probably wouldn't, although I can't recommend medication, right? I'm a chiropractor. But anyway, the research says you better be careful with them. So they're designed to be used in addition to a proton pump. Classic ones, here's the classic ones, no stars. I'm not going to make you know these because I don't think, at least in this country, most of them are banned. This was the big one, this cisapride. had some pretty good research behind it, but Europe and US it's banned because of the arrhythmias, it's called. Erythromycin, it's just an antibiotic. You take it at a very low dose and it may cause some tightening of the muscles. And here's the serious side effects. We said these prokinetics have been found to cause not only depression, anxiety, drowsiness, fatigue, involuntary movements, because it causes muscle contractions. But the big one, heart arrhythmias. So cisapride was removed because it was killing people. Ventricular flutters and arrhythmias are very dangerous. PPIs, we got to talk about them. You definitely need to know the PPIs. 40% of Americans may be headed down this pathway, so these are going to be coming in your office. Over-the-counter, Prilosec, Prevacid, Protonix is prescription. That one's my favorite. I've tried, I think, every single one of these things. Best one for me, but it doesn't mean it will work for you, but that seems to be a good one. Okay, you can read the rest of the names, but know these because for sure there's going to be a question on the test on those. But osteoporosis wild card. Stanford, I was treated by Stanford. They weren't worried by it. I know Mayo Clinic is not worried about it yet, but there are some studies coming out. Like I said, that's not a fire yet where big centers are going to stop prescribing them. But there's some smoke. We're going to look at that in a minute. PPIs, they're absorbed rapidly right through the stomach wall. They're sucked up. They got to take them on an empty stomach in the morning. That's why they need to be sucked in through the stomach epithelium. And they get sucked up into the parietal cells of the fundus glands. And they bind to the hydrogen, potassium, ATPase pumps. We won't get into the mechanism, but it can basically block all those receptor sites. And it doesn't, it screws up the mechanisms which produce acid. I used to make you guys know the mechanism, how to build a hydrogen, but I'll leave that to biochem at this point. I think that's probably too deep for this course. So the trouble with these things is the stomach is smart, and you can make new proton pumps within those fundus glands. And so when the pH starts rising, there's triggers that will say, hey, we better make some more proton pumps. Whatever's happening, you guys aren't working right. And so you do start creating new proton pumps. But that can take hours. And by the time they create new pumps, if you don't eat too big of a meal, most of that food is gone and it will shut off and you won't have a trouble with it. But some people need to do double doses of PPIs because they just make a lot of acid or they have a high stress job. But yeah, much better than H2 blockers. Here's another study that was done in the New England Journal of Medicine, right? #1 journal in the world. It's an older study back in the 95, but they tested these patients to see if PPI by itself or a PPI combined with a prokinetic got better improvement on these patients. And you can say, here's the PPI that gave really good relief, much better than the H2 blocker by itself, was about half as effective, which seems about right. Prokinetic by itself is not much better. But when you combine the PPI and prokinetic, you get a better effect. However, this difference was not statistically significant. It wasn't lower than 0.05, but I think it was close, but not quite that much. So bottom line, in my opinion, it's not worth messing with a prokinetic. Try the PPI, try different types of them, and talk to your doctor, right? Talk to your gastroenterologist. Most recent studies, the success rate of PPIs. This is a meta-analysis, right, by Ren. Always go for meta-analysis. Is study of all the good studies. It's the best you can do. 13% of people with real bad GERD, to the point they got erosive reflux esophagitis, they got no relief. But that's about 7% of people got pretty good relief. Maybe these 13%, maybe they were still breaking some of the eating rules, or maybe they were forgetting to take their medication, who knows. But they give pretty good relief. Now, patients with NERD, the NERDs are tough to treat. 45% of them got no relief. So NERD is a pretty tough condition. We don't understand it quite yet why that is. About half of them get about a 50-50 chance if you're a NERD that they'll work. Why not 100% effective? Because, as I said before, proton pumps can be made really quickly in the parotid or in the fundus glands. Well, not really quickly. It takes a while for them to get going. But if you've eaten a big meal, there's enough time for new proton pumps to be made, which aren't going to be blocked by the PPI because they're brand new. And maybe your food will be gone and you'll be sleeping, and they'll start making nocturnal acid, and you'll wake up in the morning, your stomach will feel terrible because of this nocturnal acid. What's the fix? You can try using H2 blockers at bedtime. And again, disclaimer, talk to your gastroenterologist. I'm just, this is not a professional opinion. This is just based on the research, what I'm talking about here. But the authors say adding an H2 blocker before bedtime is, you could try to prevent that nocturnal acid. There's some other causes of GERD-like symptoms. Medication can irritate your esophagus. Some people, especially some antibiotics, can cause upset stomach and GERD-like symptoms, as well as dyspeptic symptoms. Certain diseases, we'll look at these two, pemphigus vulgaris and bullous pemphigoid, actually the first week. Horrible diseases. Pretty rare, but they can also are associated with skin conditions, as we will see. These are blistering diseases. They're both autoimmune. We'll look at those in 7th quarter. Eosinophilic esophagitis. I got a YouTube video on that one already. That can present like GERD symptoms. Heart disease, we already said that. What about an infection of the esophagus? That can cause GERD-like symptoms. People with delayed gastric emptying. Their low esophageal sphincters may be normal, but food stays in their stomach forever. Acid can seep its way back in there, so that can cause real GERD-like. That will cause GERD. Some people are hypersensitive. They have too many nociceptors, too many pain-carrying fibers built into their esophagus. So maybe they don't have any damage, but they're just super sensitive. Same with back pain, right? Some people, it's believed they have way more pain-carrying fiber in the facet joints and in the disc, and therefore everybody experiences pain differently. Now, somatic features, depression, other psychological conditions, just like back pain, they can also have GERD-like symptoms as well. Rumination is a problem. Some people become so focused on their pain. They join those online talk support groups, and they're immersing their brains in pain and pain. Try to not join those groups. Go there to get information, and then don't let that become your, I'm going off on a tangent now, but don't let that become your life. You don't want to keep thinking about it. That's the same with back pain, any type of pain. Those things are not good. That keeps reinforcing things. And I won't go down that path. I was just thinking about arachnoiditis patients, and I won't go there. I'll hold my tongue. But that's rumination. You're just thinking about things too much. Length of treatment. Some patients, after 6 months or so, you can try to start stepping down, maybe take a half a proton pump inhibitor, cut them in half, and try to replace them with H2 blockers. The worry is about osteoporosis. That's very difficult. Very rarely, once people are on these for more than 6 months. I was on these for years. I'm a rare one, but I figured out what was the matter with me and how to deal with it. But most patients end up being on PPIs for life. Some people believe that when you go off the PPI, there's a rebound phenomenon where your parietal cells or your fundus cells are used to making more proton pump inhibitors quickly because they know that the PPIs are going to block them. And when you stop the PPI, they keep making extra proton pumps, and then you get too much acid. That's the theory there. And then when you stop the PPI, it just kills you because it takes a while for your body to realize, oh, there's no more PPI around. I don't have to make all these extra cells. That's the theory. There's some new research that says this is kind of a myth, some pretty good research. So I'm not sure if it's kind of a psychological thing where you've read and you've heard on the internet, oh, there's a rebound. But I quit cold turkey. Once I had things figured out, I didn't taper off them at all. I just stopped, and I did fine. It was kind of rough for about a week, and then I was better. Yeah, everything I said right there. Therefore, when you stop PPIs, everything I just said already. Some debate over this issue. I did leave it in. Systematic review, again, performed by Hunfeld, 2006. They took 8 really quality studies and combined them. There's some problems, though. They're heterogeneous, the top studies. They weren't all exactly the same type. The bottom line is most of the studies did not find any evidence for this weird rebound of hyperacid after stopping PPIs. Some of the uncontrolled trials suggested that it existed, but so it probably does not exist, but it's probably a psychosomatic type thing, but kind of stay tuned on that one. Decreased acid screws up medication delivery. There's other reasons PPIs are bad for you. They screw up if you have to take other medications. You got to be careful with these things because they can screw up. They can make too much medication get into your system, or they can block medication so it doesn't get into your system. So interference. Digoxin, a lot of people on that for heart problems. PPIs cause an over reabsorption of digoxin. So you take digoxin, you end up taking 20 milligrams. It's like doubling the dose if you're on PPIs. So make sure you tell your doctor if you're taking over-the-counter ones. Got to be careful. This causes all sorts of heart arrhythmias, deadly heart arrhythmias. We'll talk about that when we talk about EKG. Warfarin, it screws up warfarin as well. It screws up the INR, makes it too high. So it's like taking too much warfarin. You could get a hemophilia. You can bleed too much from it. So you have to adjust it. Decreased absorption in cancer drugs, that's not a good thing. If you have cancer, you want all that medication getting in there. Decreases AIDS drugs, antiviral drugs. Decreases B12, right? We're going to talk a lot about pernicious anemia. So there is some evidence that long-term use of PPIs can cause pernicious anemia. Not great research, though. Osteoporosis, as we said, it could increase the risk for osteoporosis. Osteoporosis is, you cough really hard or sneeze and you fracture a rib or something, or you vomit and you can get compression fracture. It's a big problem. That's for real. As I said before, Mayo Clinic and Stanford both say it's safe. There's a big study came out in 2016, though, the Jacob study, where PPIs were associated with osteoporosis. So let's take a quick look at that. Now, the object of the study was to analyze the association between PPIs and osteoporosis. The only problem, it was in postmenopausal women, older women. So does that apply? Does this result apply to general population? We don't know. Probably, but we don't know. So they investigated the use of PPIs in 3,000 women who had osteoporosis and 3,000 women who didn't, were the same age, body type matched, and they followed them, and they analyzed their data to see see if they could figure out what was any factors for this osteoporosis. And sure enough, PPIs were more commonly used in people with osteoporosis than the ones who didn't have osteoporosis, and it was significant, less than 0.05. Osteoporosis patients, this was the surprise finding, they had more GERD, more GI disorders, statistically significant, 0.05. And so we don't know why, but there's definitely something to that we haven't figured out yet. And just osteoporosis patients had more comorbidities in general. They had erosive esophagitis, they had gastritis, all these GI problems. So something about that osteoporosis. So the odds of developing osteoporosis significantly increased as the duration of PPI therapy increased. The authors concluded the use of PPIs was a risk factor for osteoporosis, and this risk increased the longer they were on therapy. So, but the obvious problem with the study, which the authors admitted, this was older females. Does that carry over with the general public? We don't know yet. This is a pretty new study, but maybe they'll look at that. Failed PPI therapy, what's next? By far the gold standard treatment. So what if you got erosions, you're bleeding, you're miserable, you can't eat, you're getting skinny? What are you going to do? The end of the road treatment and the gold standard treatment is called the fundoplication. Remember the fundus of the stomach? We're going to wrap that around the abdominal esophagus like a hot dog, like a hot dog bun around a hot dog. So it's a surgical procedure designed to fix the lower esophageal sphincter, its lack of tone. In general, you loosen up the fundus from its connections, which is easier said than done. The stomach's anchored down there pretty good. You stretch and wrap the fundus around the esophagus, and you sew the two ends together, and that's it. There's kind of a cartoon of it. There's the stomach, right? Duodenum is here. There's the diaphragm, esophageal hiatus. There's the abdominal esophagus, and they took the fundus, which is like a little pouch, and stretched it around and created a new lower esophageal sphincter. And you can immediately see the problem. I know my students are going, oh my God, that's terrible. What's the problem? This will grow together. This tissue grow right together. So you're going to go, is it going to fix GERD? You're not going to have any acid reflux, that's for sure. But what's the problem? You're going to have dysphagia, or you're going to have odonophagia. You're going to have trouble swallowing because you got to squeeze food through there, and there's no way to relax this, right? It's like that all the time. So fortify the lower esophageal sphincter. They also repair if you have a hiatal hernia. They'll fix that. Tighten the esophageal. They can put a couple stitches in the esophageal hiatus if that's loose. And they can tighten up the crust to give that some power as well. All right. Let's do Barrett's esophagus. This is longer than I thought. We need to do a little pathology here first. Metaplasia, what in the heck does that mean? Remember Cooperstein's class, pathology. Metaplasia, if a tissue gets stressed enough and beat up enough, pretty soon it's going to say, you know what, we need to, the stem cells that are creating these new epithelial cells, those stem cells are going to say, hey, this is ridiculous, let's make a tougher tissue. And that's what it does. You used to have one type of epithelium, and now you have morphed into a new type of epithelium that's better able to withstand its new tough environment. That's called metaplasia. So typically metaplasia involves columnar cells morphing into squamous cells. That's not the one we're going to study, but that's happens. Classic example is cigarette smokers who morph their bronchial tracheal tree into a tissue other than pseudostratified ciliated epithelium, so they lose their pump. We're going to talk about that though. Pollution, so classic triggers. What can cause metaplasia? Cigarette smoke. Pollution. You live in a really polluted area. NSAIDs, aspirin rips up things. And then GERD, regurgitation of acid, pepsin. Smoking, let's talk about that quickly, kind of digress a little bit. But you're going to see this in cardiovascular pulmonary pathology as well, which I teach. So damages the native pseudostratified ciliated columnar of the tracheobronchial tree, the smoke, the cigarette smoke particles, beats up the ciliated columnar epithelium, and pretty soon the stem cells that create those cells are going to say, that's it, we're not going to make any more of these things. So they make something stronger. How about stratified simple squamous? And that's what they make. Fortunately, it's non-ciliated, and so you just lost your cilia, So therefore, if you breathe the pollution of the day or cigarette smoke or whatever, you need to cough that stuff up. It needs to be swept out of your tracheobronchial tree, and you can't sweep it. So the only way you get it out is to cough like you're dying in the morning. Anybody know a heavy smoker? They get up in the morning and they cough and they cough and they cough. It's because they don't have a nice mucus escalator like most of us do. Here's the mucus escalator. I've asked questions on this, so watch this. Good board review too. So here's your pseudostratified ciliated columnar epithelium, nice and beautiful in a patient. I'm surprised my previous classes don't know this. Remember the mucus that makes this conveyor belt? There's two types of mucus that have to be made. Cystic fibrosis screws this thing up, but normally there's a really loose, thin type mucus that lines the very surface of the epithelium. That's called the sol layer, or the sole layer, however you want to say that. Called sol layer, or thin layer. Then on top of that, the thicker mucus is like fly paper. Catches bugs, cigarette smoke, car exhaust, pollen from the air. Catches all this gunk. And the cilia sweep this whole system upward, toward the larynx. And then you can either spit it out or swallow it, whatever you want to do. That's all I'll say about that. So smoking breaks the mucus escalator system, and because those cells are wimpy, they're not designed to have harsh cigarette smoke particles and things like that. They get beat up and they morph into squamous, stratified squamous. And now that they're morphed, when you do a histological sample and you find squamous where there's supposed to be that pseudostratified ciliated columnar, you've got yourself a metaplastic condition. Cells have mutated. No, they haven't mutated. They're still pretty cells, but they're just the wrong tissue type in the wrong place. Now, when they start mutating and getting crazy looking, that's called dysplasia. That's pre-cancer. So there's different stages. There's of dysplasia, 2 stages. Some pathologists have 3 stages. But those, no bueno, right? That's precancerous stuff. And that could easily morph. If enough of these cells mutate, you got yourself a full-blown cancer. So here's an example of metaplasia this is a smoker, and this is more upstream, so the smoke has been hitting this area. Pretty soon this whole thing will morph, but here's the native pseudostratified ciliated columnar epithelium right here, and now it's been the stem cells that you can't see down here. They've said, forget it, we're not making any more. And here is a nice stratified squamous that's been laid down. But this is metaplastic tissue now. And that's got a chance to go on to become dysplastic tissue. And that's got a chance to become cancerous. So you could say metaplasia is one step toward cancer. Barrett's esophagus. It's acquired metaplastic / dysplastic condition of the esophagus. I like this. This is a serious condition, so watch out. Lots of Jekyll and Hyde. There's the squamous, it's going to turn into columnar, as we'll see. So, one of my pet peeves, a lot of the Rubens and Robbins, they say that a metaplasia has occurred, but metaplasia is not technically precancerous. So everybody knows Barrett's esophagus is precancerous, yet most of the time the cells are only metaplastic. They're not mutated. They're not dysplastic. Some of the more research-oriented authors use this correctly. I don't know what to say about that. The board books, Rubens and Robbins, they should really say dysplastic is precancerous. So really, technically, Barrett's esophagus, if they only have a metaplastic condition, they kind of have like a pre-cancerous condition. Although some people have flat-out dysplasia. And this metaplasia can go into dysplasia and be precancerous pretty quickly. But I'm not sure why, where that came from or why they don't explain that better. What's the cause of a Barrett's esophagus? we know the answer. The same answer causes GERD, loose lower esophageal sphincter. So these are GERD patients. The hypertonic sphincter allows for chronic reflux of our friends hydrochloric acid and pepsin in the stomach. GERD. So GERD causes a Barrett's esophagus. Having too much hydrochloric acid, having too much pepsin, bathing your esophagus, not good. Your cells aren't going to take it. They're going to morph into a new tissue type. They're going to become metaplastic and then become dysplastic. They could become dysplastic. That's precancer. And then they could become full-out cancer. People with chronic reflux, especially the scary part about this, some people have no symptoms. They can go right through these phases, and for whatever reason, they just weren't given enough nerve fibers to tell them that they had erosion starting, and they can get esophageal cancer without having. And we'll take a look at that number in a little while. How do you make the diagnosis more specifically? Nice paper from Yin, 2019, brand new, really laid it out nicely. And this matches Rubin's and Robbins pretty much. To make the diagnosis, you have to, first of all, order 2 tests. You have to stick a scope down, an endoscopic evaluation of the esophagus. And you have to take samples. Okay, so endoscopic evaluation with histologic sampling. You got to take little biopsy sections of that esophagus. And then you got to give the histological samples to the pathologist who's going to analyze those samples. Okay, now to be positive for Barrett's esophagus, you need another 2 factors. Number 1, you have to, when you're doing the endoscopy, you have to be able to see an elevated Z-line. Remember we said in class the Z-line is normally right at these folds. Remember these are the gastric folds where if you're Ant-Man and you're going to run through this hole, you're going to be in the stomach. This is the lower esophageal sphincter pinching the tube. This is an endoscopic view. You have a like a long cable with a camera on the end of it stuck down your throat. Or they can go through your nose, but it's all the way down. It's going to head toward your stomach. Right before you get into your stomach, this is what you see. The tissue's all pinched. This is the lower esophageal sphincter, and we can see the 2 colors. This light pink tissue, see that? That is your stratified squamous of the esophagus. This salmon, the authors call this salmon color. I guess it is salmon. This is simple columnar tissue of the stomach lining. It's not going to have mucus glands. This is normal. So normally, and this is the line between them, that's the Z line. It doesn't look like it does in books, does it? Sometimes it's perfectly round. I mean, this one's a little more jagged, but that's the Z line. This is normal. Now let's see someone who has an elevated Z line. Oh, well, let's not see him yet. Let's look at this cartoon. So here's the stomach. This patient's got a hiatal hernia too. We'll talk about those later. Bottom line is, there's the gastroesophageal junction right there. Let's look at this one first. There's the gastroesophageal junction right here. And so normally, you should not have the Z-line above that. This patient has Barrett's esophagus starting. The Z-line is a little bit above it. Maybe some endoscopists might miss that, but not that big of a deal yet. This patient, if it goes more than 3 centimeters above the gastroesophageal junction, that's a problem. That's long segment BE. This is much more likely to turn cancerous than short segment BE. Might be getting too deep for this course. I took the stars off there, but that's the way it works. Normally, this orange tissue would be exactly not exceeding this line here, and the folds, the gastric folds would be right here. Now let's look at a real one, okay? I don't know if I should take that out next time. Here's normal. Okay, there's the Z line. Great. Whoa, that's not good, is it? The gastric folds are way down inside here. Okay, so this tissue, this is all This tissue is not supposed to, this is all simple columnar. And the pathologist, if he finds that this has goblet cells, okay, quiz question. Are there goblet cells in the stomach? No, all the cells secrete mucus. You don't need goblet cells. In the intestines, they don't secrete. So you need goblet cells to secrete mucus. This tissue is filled with goblet, if it's filled with goblet cells, you got yourself intestinal metaplasia. So this is intestinal tissue. It's not stomach tissue like the normal pink tissue is. Like this, that's just like fundic tissue. If you sample this, you'll see simple columnar. There might be some funded glands. There's probably cardiac tissue from the cardiac region, which doesn't have any of the funded glands. That's normal. What would be normal? If it had funded glands in it, that would be a little abnormal, but it wouldn't make the diagnosis. So you need two factors. We saw one factor to make the diagnosis. You need that. So you need the stomach tissue, the salmon-colored tissue, to come way above the lower esophageal sphincter. And then number two, the histologist has to find metaplasia, but specifically, it has to be intestinal type columnar metaplasia. So it has to be a intestinal, or it has to be an epithelium that would normally only be found in the intestine. Okay, got it? And therefore, it's going to be filled with goblet cells. That makes the diagnosis of a Barrett's esophagus. Pathologists might not find that. They may find that it's fundic type columnar, just the regular O type. Remember we said this, normal pink stuff, that's simple columnar, that's cardiac, that's from the cardiac region of the stomach. So that's no big deal. It's cardiac columnar metaplasia. Maybe it's a little fundic mix in there. Maybe there's some fundic glands. Maybe it secretes a little acid. If there's fundic glands, it would. You could have an HP infection in there, right? Or did we study that yet? I can't remember if we studied that yet. I think we did. But this does not make the diagnosis of Barrett's esophagus. It has to be the intestinal type of simple columnar to make that diagnosis. Got it? Oh, forgot to put stars. You better put stars in the slide. Sorry, I just made this one up today. Put stars on here, because this, when I trim your slides down, if I keep this in, it'll be stars there. Histological, there's no stars here though. Here's normal stratified squamous, right? There's the basal layer where the stem cells are, and it's got that. Remember, it's modified. It doesn't have 5 layers, but there's a cornicytes on the top. That's just like a run-of-the-mill stratified squamous. It doesn't have no keratin in it, so you could tell it apart from the skin, but very protective, or very not very good for acid. Right? Acid can rip its way through there easy. So here's a patient who has a Barrett's esophagus. Where to go? You can see all the columnar cells are here. They have microvilla on the top of them. Right? The author forgot to mention that, but they do. You can see the microvilla right there. And look at all these goblet cells. Right here you can see beautiful goblet cells. You don't see any. You see like holes in that's just from the preparation. But those are flat out goblet cells. So no good. That's the intestinal type of metaplasia. This patient's got Barrett's esophagus, and it definitely has an increased risk for going into dysplasia. These two patients, they've went past the metaplasia and they've went right to the dysplastic. This is definitely, these are both precancerous conditions. So these people, the gastroenterologists, will be much more worried about them than an early Barrett's esophagus. They're still worried about him, but they're really worried about him. And here, of course, this is no good. There's no organization. These cells are, cancer cells live forever. They don't die. They're all mutated. You can't see any rhyme or reason to this. This is all layered. You can see the layer, different spinosum layer. You can see everything, basale layer down here. Can't see that. Just a big mess. That's cancer. Patients, 17% will be dead within, only 17% will be alive even with treatment within 5 years. It's a nasty, nasty disease. So if metaplasia morphs into dysplasia, then the risk for the development of cancer, so going from dysplasia to cancer, is 40-fold increase. It's from Mayo Clinic. That's really, really risky. So people got to have a scope stuck down there every 6 months or even every 3 months. Keep an eye on that. Okay, what do you think of this one? You can see the folds. There's the folds. So we're at the lower esophageal sphincter. This is coming up too high, so it's not as bad as the other one we saw. But you do a sample of this. You wouldn't know from this picture if there's cardiac columnar in here or fundic columnar, simple columnar cells. This one actually turned out to be intestinal columnar or simple columnar epithelium. So this was a Barrett's esophagus. It's got to be watched. Everybody good? I'm not going to go crazy. I took most of the slides out. I could go on this stuff, but let's just get to the facts. Esophageal carcinoma, horrible prognosis. That's why Barrett's esophagus has to be watched so closely. 5-year survival rate, about 17, 20%. Actually, I think it's between 15 and 20%. I was going to just leave 70% in there. In 2005, from this text or from this paper, killed 400,000 people in the world. Not good. 8th most common cause of death worldwide, 16,000 new cases diagnosed each year. Symptoms of cancer are just GERD symptoms, but when it gets really bad and starts, I shouldn't say that. Cancer, usually by that time, you're going to have some severe symptoms, but usually as you go through the stages, you're going to have a solid food dysphagia. What does that mean, solid food dysphagia? You have trouble swallowing because it hurts, right? The esophagus is raw from the cancer, has ripped it all to pieces, so it hurts. You can still eat liquids, but pretty soon, maybe 3 months later, now you're having trouble eating soft food like soups and macaroni and things like that. Then pretty soon, you can't even drink liquid. Hurts. Horrible sign. And then you're, of course, going to have weight loss because you can't. They call it unintentional, but I mean, you can't eat because it hurts. The scary thing about this type of cancer is not all people have GERD symptoms. So it may or may not have those burning GERD symptoms. In this study, 45% of patients with esophageal carcinoma had either no or very rare GERD symptoms. They go and have spicy food and they get so many Americans. Like half of the Americans are like that. So almost 50%. So this is kind of a scary one. I really believe that everybody who, I know they say to do a colonoscopy once you're over 50, is it? Some sources say 40. But you should also have, when they do that colonoscopy, you should have somebody stick a scope down your esophagus to make sure everything's okay there. The very end phases, we looked at this in lab, right? Trousseau's sign, your left supraclavicular lymph node is swollen up like crazy. Bad sign, right? That's called the sentinel node, left sentinel, or the Virchow's node. It's only on the left side, or left supraclavicular node. It's lymphadenopathy. Very bad sign. Making the diagnosis, you need a CT scan. Endoscopic eval and tissue, you need that too. CT needs to be ordered to make sure it hasn't metastasized. It likes to go to the lung and brain. And you can do a PET scan, is even better than a CT. It's much more expensive, but you should do that. Greater sensitivity than CT for ruling out metastatic disease. It basically, you drink or inhale a mist that has radioactive molecules that stick to cancer cells. They bind to them. And so after time goes by, you give them a chance to go throughout your body. They'll find the cancer and bind to it. And then you can do a scan of them, like this patient. So he's got cancer, esophageal cancer right here. He's got also down here down at the lower esophageal junction. So that's where all those cells stuck and bound. There's 2 types of carcinoma. By far the most common is adenocarcinoma. That's the one that we're talking about. That's associated with GERD, Barrett's esophagus, much more common. There's also squamous cell carcinoma. That's the one related to smoking. That's been on the decrease because the world is catching on that smoking is really, really bad for you. Hey, we made it. 103 slides. Okay, don't forget to thumbs up if you like the video, right? Subscribe to my channel so you can, if you're into this stuff. And for my students, don't forget, I'm posting this on Brightspace, so this is fair game. This is our Thursday lecture. All right, see you in the next video.